Welcome to Chapter 29, entitled Pharmaceutical Care and Cardiovascular Diseases. Cardiovascular diseases, abbreviated as CVDs, are often accompanied with comorbidities and, therefore, with multiple drug regimens. Drug-related morbidity and mortality due to drug-related problems, abbreviated as DRPs, represent a serious problem in these patients. Pharmacists' intervention can detect and solve or prevent drug-related problems. However, drug-related problems in cardiovascular diseases are currently not a validated surrogate outcome. Nevertheless, suggested interventions are medication reconciliation and reviews, patient education and counseling, to improve self-care and medication adherence, additional written information, medication plan, and pillboxes, weekly dosing aids, to improve adherence, and monitoring of clinical parameters, among others. Apart from hypertension and cardiovascular disease risk reduction, randomized controlled trials, abbreviated as RCTs, with robust designs, studying large populations, adequate follow-up periods, and sufficiently powered to detect clinical relevant differences in endpoints are needed. The evidence gained will provide standards for the interventions and outcome measures, both to compare studies and approaches to implement them reimbursed in daily pharmaceutical practice. We will begin with an introduction. Cardiovascular diseases, abbreviated as CVDs, are the #1 cause of death globally. The World Health Organization, WHO, reports that 17.5 million people die each year from cardiovascular diseases, an estimated 31% of all deaths worldwide. 4 out of 5 cardiovascular disease deaths are due to heart attacks and strokes. Over 75% of cardiovascular disease deaths occur in low-income and middle-income countries. Cardiovascular diseases are caused by disorders of the heart and blood vessels, such as raised blood pressure, abbreviated as BP, hypertension, abbreviated as HT, and coronary heart disease, abbreviated as CHD. They include angina, acute coronary syndromes, abbreviated as ACS, including myocardial infarction, MI, heart failure, abbreviated as HF, cerebrovascular diseases, stroke and transient ischemic attacks, abbreviated as TIA, peripheral artery disease, PAD, rheumatic heart diseases, and congenital heart diseases. Individuals at risk of cardiovascular disease often have hypertension, dysglycemia, and dyslipidemia as well as overweight or obesity. These can all be easily measured and monitored by pharmacists. Identifying those at highest risk of cardiovascular diseases and ensuring they receive appropriate treatment can prevent premature deaths. The major lifestyle risk factors of cardiovascular disease are tobacco use, physical inactivity, an unhealthy diet, and harmful use of alcohol. It is possible to prevent cardiovascular disease by addressing these behavioral risk factors. People with cardiovascular disease or at high cardiovascular risk need early detection and management, including counseling and pharmacotherapy. The WHO identified cost-effective interventions for prevention and control of cardiovascular disease, e.g., comprehensive tobacco control policies, taxation to reduce the intake of foods that are high in fat, sugar and salt, building walking and cycle paths to increase physical activity, and individual healthcare interventions to be targeted to those at high cardiovascular disease risk. For secondary prevention of cardiovascular disease in those with established disease, treatment with medications like aspirin, abbreviated as ACE, beta blockers, abbreviated as BBs, angiotensin-converting enzyme inhibitors, abbreviated as ACEI, and lipid-lowering drugs, mostly statins, is necessary. The complexity of the guideline-recommended therapies increases as the disease progresses due to increasing comorbidities requiring additional treatment by different specialists. This increases the probability of drug-related problems, abbreviated as DRPs, such as drug-drug and drug-food interactions, contraindications, duplicate medications, and adverse effects, abbreviated as ARIE. Moreover, actual medication intake by patients often differs from the recommendations made by healthcare professionals. Medication non-adherence is, hence, another major issue. For many patients, it is difficult to self-manage their many pharmacological and non-pharmacological treatments. More on medication adherence can be found in Chapter 5. So, multidisciplinary approaches to treatment and care are promising to reduce hospitalizations and mortality, eventually. The benefits of these interventions are largely independent, but when used together with smoking cessation, nearly 75% of recurrent vascular events are potentially preventable. Currently there are, however, major gaps in the implementation of these interventions, particularly at the primary healthcare level. Next we will discuss disease characteristics. Hypertension and dyslipidemia are the most common cardiovascular disease risk factors, and coronary heart disease and heart failure are by far the most common cardiovascular disease. Therefore, this section covers these four conditions. Next we will discuss dyslipidemia. Dyslipidemia is a major risk factor for cardiovascular disease including stroke. The most common dyslipidemia is elevated low-density lipoprotein cholesterol levels, which directly relate to risk of atherosclerotic vascular disease. Dyslipidemia targets recommended by major cardiovascular guidelines are all based upon calculation of an individual's risk for cardiovascular events. See the guidelines for various cardiovascular risk calculators. The approach to LDL-C targets vary by guideline, and either call for a 50% reduction in LDL-C, targets based upon cardiovascular risk, e.g., a target of less than 2.0 millimoles per liter in those at high cardiovascular risk. See www.onlinecjc.ca/article/S0828-282X16-30732-2, PDF and https://www.ayers-society.org/?page equals dyslipidemia_guide, or simply to use high-dose statins in all patients at high cardiovascular risk. See Circ. AHA-journals.org/content/circulation/133/18/1795.full.pdf. Next we will discuss hypertension. Hypertension is a condition in which the blood vessels have persistently raised pressure. Raised BP is one of the leading risk factors for coronary heart disease, heart failure, both ischemic and hemorrhagic stroke, and subsequently, for global mortality. In some age groups, the risk of cardiovascular diseases doubles for each increment of 20/10, systolic, diastolic, mm of mercury of BP, starting as low as 115 systolic 75 diastolic. Next we will discuss coronary heart disease, abbreviated as CHD, coronary heart disease, as a result of coronary artery disease, abbreviated as CAD, causes exercise and stress-related ischemic symptoms due to narrowing of 50% in the left main coronary artery and 70% in one or several of the major coronary arteries. Coronary heart disease is characterized by episodes of reversible myocardial supply mismatch, related to ischemia or hypoxia, commonly associated with transient chest discomfort and pain, angina pectoris. The various clinical presentations of coronary heart disease are associated with different underlying mechanisms that mainly include 1. Plaque-related obstruction of epicardial arteries. 2. Focal or diffuse spasm of normal or plaque-diseased arteries. 3. Microvascular dysfunction. And 4. Left ventricular dysfunction, abbreviated as LVD, caused by prior acute myocardial necrosis and/or hibernation, ischemic cardiomyopathy. We will now discuss heart failure, abbreviated as HF. Heart failure is a highly morbid and costly condition with a growing impact on public health, affecting approximately 1 to 2% of the adult population in developed countries. Hospitalizations for acute decompensated heart failure, abbreviated as ADHF, are common, and the mortality is high despite guideline-directed treatment. Heart failure is characterized by typical symptoms, e.g., breathlessness, various degrees of dyspnea, ankle swelling, and fatigue, that may be accompanied by signs, e.g., elevated jugular venous pressure, pulmonary crackles, and peripheral edema. It is caused by a structural and/or functional cardiac abnormality, resulting in a reduced cardiac output. Before clinical symptoms become apparent, patients can present with asymptomatic structural or functional cardiac abnormalities. Identification of the underlying cardiovascular problem or problems, mostly undiagnosed or poorly managed hypertension or coronary artery disease, is crucial. Heart failure is categorized by the percentage of the left ventricular ejection fraction, abbreviated as LVEF. There are patients with normal left ventricular ejection fraction that is 50%. Heart failure with preserved ejection fraction, abbreviated as half PEF, with reduced LVEF, that is below 40%. Heart failure with reduced ejection fraction, abbreviated as half REF, and with a left ventricular ejection fraction in the range of 40 to 49%. Heart failure with midrange ejection fraction, abbreviated as HFMREF. Next we will look at treatment goals. Let's begin with hypertension. Blood pressure lowering drugs are strongly recommended to reduce the risk of cardiovascular outcomes, e.g., stroke, acute coronary syndromes or myocardial infarction, and heart failure, in all individuals with hypertension. Treating systolic and diastolic BP to a target below 140 systolic 90 diastolic is associated with a reduction in cardiovascular complications. Treatment includes lifestyle modifications, which is first line. The introduction of pharmacotherapy is linked to overall cardiovascular disease risk. Diuretics, including thiazides, chlorthalidone, and indapamide, beta blockers, calcium channel blockers, and angiotensin-converting enzyme inhibitors, abbreviated as ACEI, or angiotensin II receptor blockers, abbreviated as ARBs, are all suitable for the initiation and maintenance of antihypertensive treatment. Next we will discuss coronary heart disease. Management of coronary heart disease aims to reduce symptoms, improve prognosis, as well as prevent cardiovascular events. It includes lifestyle modifications like healthy diet and increased or appropriate physical activity, control of risk factors, like smoking, overweight or obesity, high lipids, high BP, evidence-based pharmacological therapy, and patient education. Anti-ischemic drugs like nitrates and molsidamine, beta blockers, calcium channel blockers, and ivabradine, an inhibitor of the funny channel, reducing only the heart rate in patients in sinus rhythm, are used. To prevent cardiovascular events, like myocardial infarction or acute thrombotic events, pharmacological or lifestyle interventions are used which 1. Reduce plaque progression. 2. Stabilize plaque by reducing inflammation. And 3. Prevent thrombosis. Therefore, antiplatelet agents like low-dose aspirin and P2Y12 inhibitors such as clopidogrel, prasugrel, or ticagrelor, lipid-lowering agents, such as statins, and renin-angiotensin-aldosterone system, abbreviated as RAS, blockers like angiotensin-converting enzyme inhibitors are recommended. Next we will discuss heart failure. The goals of guideline-recommended therapies for heart failure are improvement of symptoms, dyspnea, fatigue, and exercise tolerance, slowing of disease progression, improvement in quality of life, abbreviated as QOL, and decrease in hospitalizations and mortality, requiring a long-term therapy with multiple drugs. Neurohormonal antagonists, e.g. ACEI or ARB, BB, and mineralocorticoid receptor antagonists, abbreviated as MRA, have been shown to improve overall survival, all-cause mortality, in patients with HFrEF. In addition, a first-in-class composite angiotensin receptor, neprilysin, abbreviated as NEP, inhibitor, abbreviated as ARNI, valsartan plus sacubitril, reduces the risk of heart failure-related hospitalizations and mortality in patients with HFrEF. Ivabradine reduces the elevated heart rate often seen in HFrEF and has also been shown to improve outcomes in HFrEF. The use of diuretics, especially loop diuretics, should be modulated according to the patient's clinical status. Treatment of hypertension is recommended to prevent or delay the onset of heart failure. Also, counseling on appropriate fluid, sodium intake, appropriate physical activity, smoking cessation, and reduction in alcohol intake is recommended. Next we will discuss common drug-related problems often encountered in patients with cardiovascular disease. Cardiovascular diseases are often accompanied with comorbidities and, therefore, with multiple drug regimens. One study found that nearly 30% of cardiovascular disease patients taking 5 drugs, a common threshold for polypharmacy, had at least one drug-related problem. Inappropriateness of the drug, especially inappropriate drug combinations, or the dose was the most common drug-related problems, abbreviated as DRPs. A need of additional drug therapy and lack of therapeutic monitoring are common risk factors causing drug-related problems. The most inappropriate drug class for cardiovascular disease patients is non-steroidal anti-inflammatory drugs, abbreviated as NSAIDs, ibuprofen, diclofenac, naproxen, among others, including COX-2 inhibitors, also called COX-IBS. Whenever possible, non-steroidal anti-inflammatory drugs should be avoided in combination with angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, or diuretics due to the risk of raised BP and worsening of renal function. Non-steroidal anti-inflammatory drugs or COX-IBS are not recommended, contraindicated, in patients with heart failure, as they increase the risk of heart failure worsening and heart failure hospitalization. Many antihypertensives are associated with clinically significant drug interactions which may affect BP lowering or result in adverse drug reactions, abbreviated as ADR. Beta blockers may mask signs and symptoms of hypoglycemia when used with insulin or oral antidiabetics and may impair glucose tolerance, leading to poorer glycemic control. Drug-drug interactions resulting in increased plasma levels of statins increase the risk of adverse drug reactions such as myopathies. In heart failure, drug classes causing many drug-related problems include angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, beta blockers, MRA, diuretics, potassium supplements, and digoxin. Regular monitoring of both potassium levels and renal function is recommended. Moreover, thiazolidinediones, also called glitazins, and the calcium channel blockers diltiazem and verapamil are not recommended in patients with heart failure, as they increase the risk of heart failure worsening and heart failure hospitalization. Pharmacist's intervention can help to monitor and prevent the risk of developing drug-related problems, and contribute to improve clinical outcomes in patients with or at risk of cardiovascular disease. In one non-randomized study without a control group, 94% of the drug-related problems in heart failure patients were classified as preventable. During the 6 months follow-up, pharmacist interventions solved or prevented the health problem in 83% of the cases. It should also be emphasized that many patients with or at risk for cardiovascular diseases are undertreated for their risk factors. These are drug-related problems that should be a target for pharmacist interventions. And now we will look at interventions in patients with or at risk of cardiovascular disease. There are few studies evaluating pharmacists' intervention in patients with or at risk of cardiovascular disease, and randomized controlled trials, abbreviated as RCTs, are rare. However, RCTs in pharmaceutical care are often challenging to conduct. Most studies have investigated the impact of interventions in hypertension, followed by heart failure, and coronary heart disease. Pharmacists' intervention may improve the clinical management of major risk factors for cardiovascular disease, can detect, solve, or prevent drug-related problem, and may increase medication adherence. In one RCT with 723 patients, and after adjusting for baseline values and center effect, there was a 21% difference in change in risk for cardiovascular disease events, with a p-value less than 0.001 between the intervention and usual care groups. The intervention group had greater improvements in LDL-C, that is negative 0.2 millimoles per liter, with a p-value less than 0.001, systolic BP, that is negative 9.37 millimeters of mercury, with a p-value less than 0.001, glycosylated hemoglobin in those with diabetes mellitus, that is negative 0.92%, with a p-value less than 0.001, and smoking cessation, that is 20.2% reduction, with a p-value equal to 0.002. A systematic review and meta-analysis identified the following interventions: patient education, patient reminder systems, measurement of cardiovascular disease risk factors, medication management and feedback to physician, or education of other healthcare professionals. Pharmacist care was associated with a significant reduction in systolic, diastolic BP, 19 studies, 10,479 patients, negative 8.1 mm of mercury, with a 95% confidence interval, that is negative 10.2 to negative 5.9, stroke negative 3.8 mm of mercury, that is negative 5.3 to negative 2.3, total cholesterol, TC, 9 studies, 1121 patients, negative 17.4 milligrams per deciliter, that is negative 25.5 to negative 9.2, LDL-C, 7 studies, 924 patients, negative 13.4 milligrams per deciliter, that is negative 23.0 to negative 3.8, and a reduction in the risk of smoking, 2 studies, 196 patients. Relative risk 0.77, a range from 0.67 to 0.89. Another systematic review of studies, which evaluated the impact of pharmaceutical care on patients with cardiovascular disease, showed that 20 of 24 included RCTs resulted in significantly improved risk factors, i.e., high BP, elevated LDL-C or blood glucose levels, or cardiovascular risk in general, with high BP and elevated cholesterol levels as the most common surrogate outcomes with significant differences after the intervention. Interventions with significant results were medication reviews, patient education and counseling, additional written information, pillboxes, weekly dosing aids, and monitoring of clinical parameters. More on medication review and counseling can be found in chapters 4 and 7 of this book. We will now focus on hypertension. The control of BP is a major challenge in primary care. The primary outcomes of studies evaluating pharmaceutical care in patients with hypertension are, apart from BP, medication adherence and quality of life, with systolic BP as the outcome most positively impacted by pharmaceutical intervention. There is very strong evidence that pharmacist intervention improves BP control in outpatients compared with usual care. In a large systematic review, pharmacist intervention, for example, patient education and counseling about lifestyle, medication use and adherence, feedback to physician, including drug-related problem identification and recommendations for medication change, and medication management, e.g., drug monitoring, showed a reduction in systolic BP, that is negative 7.6 mm of mercury, with a 95% confidence interval of negative 9.0 to negative 6.3, I squared equal to 67%. And diastolic BP, negative 3.9 mm of mercury, that is negative 5.1 to 2.8, I squared equal to 83%, when compared with usual care. The effect tended to be larger if the intervention was led by the pharmacist and was delivered at least monthly. Moreover, a recent study demonstrated better BP outcomes and cost savings with a pharmacist prescribing intervention for patients with hypertension in Canada. Next we will discuss coronary heart disease. For coronary heart disease, a systematic review of RCTs evaluated the impact of pharmaceutical care interventions on cardiovascular events, hospitalizations, and mortality. Secondary outcomes were medication adherence, BP, and lipid management. The authors found only one study that assessed the primary outcomes with no significant effects, and 4 that assessed secondary outcomes, with significant effects on medication adherence, BP, and lipid management. Interventions delivered by pharmacists included patient education, medication management, e.g., medication review, tools to improve or measure medication adherence, monitoring therapy, feedback to other healthcare professionals, and disease management, e.g., assessment of targets for medication therapy such as BP. Next we will discuss heart failure. For heart failure, a recent systematic review identified 3 important fields for primary, that is ambulatory or community, pharmacist care. 1. Medication reconciliation and reviews. 2. Self-care and symptom control. And 3. Medication adherence. 8 RCTs were included and 7 systematic reviews were analyzed additionally. Pharmacist interventions consisted of a structured interview with the patient, e.g., guided and documented by an assessment tool such as the 1-Minute Clinic for Heart Failure, abbreviated as TOM-CHF, where drug use and reasons for medication non-adherence were discussed, as well as a follow-up of the supply with electronic devices, such as MEMS, regular communication with the patient about the therapy, monitoring with MEMS and written instructions, medication reconciliation, and reviews to optimize medical treatment according to guidelines and to improve medication safety, written information for the patient and instructions for self-care, home visits including a medication review, as well as advice on symptoms, self-management and lifestyle. Primary outcomes were a combination of the 2 minutes walk test, BP, body weight, pulse, forced vital capacity, abbreviated as FVC, and quality of life, medication adherence, adverse drug events, abbreviated as ADE, and medication errors, hospital admission, as well as a composite of hospital admission and death. 6 RCTs found statistically significant effects on primary outcomes, whereas 2 studies found no significant differences. This systematic review showed an improvement in cardiovascular risk factors due to pharmacist intervention, a reduced risk of hospitalizations due to collaboration between pharmacists and physicians, including medication reviews, as well as due to pharmacists monitoring for contraindications and drug interactions. Moreover, educational and counseling interventions, including instructions on self-monitoring, recommendations to physicians, and adherence aids, were identified as promising interventions. 2 meta-analyses of RCTs in heart failure have reported reductions in all-cause hospitalizations of 21% and 29%, respectively, when the multidisciplinary intervention contained elements of pharmacist care. With a largely static therapeutic armamentarium in heart failure, maximal application of existing RCT-proven therapies is increasingly important. The dangers of deferring heart failure therapy are obvious. Drugs can't work in patients who don't receive them. A structured medication review offers the opportunity not only to reconcile the medication but to identify undertreatment of heart failure, both in terms of drug classes and doses prescribed or used. Pharmacists can play a critical role in addressing the ever-growing complexity of polypharmacy for heart failure, incorporating medications for comorbid conditions, and orchestrating dose titration of cardiovascular medications, as well as integrating newer medications such as sacubitril valsartan or ivabradine. Next we will discuss disease management programs. Adequate patient education, with special emphasis on adherence and self-care, are common components of management programs for patients with heart failure. These programs should employ a multidisciplinary approach: cardiologists, primary care physicians, pharmacists, nurses. The 2017 update of the German National Guideline on Chronic Heart Failure, abbreviated as CHF, included a specific statement supporting the integration of pharmacists in the care of heart failure patients. A further statement recommends a standardized medication plan, a complete list of prescribed and OTC drugs, for every heart failure patient. Physician and pharmacist should coordinate issuing and updating the medication plan with the main aims to improve patient safety and medication adherence. A consolidated medication plan shall be a result of a coordinated medication review. However, assuring that patients understand the standardized medication plan and can transfer the given information into practice is necessary. In addition to aid the patient, a complete and up-to-date medication plan also informs healthcare professionals about a patient's current medication. Hence, bridging the gap between providers and settings. It, therefore, can help to detect, solve, and prevent drug-related problems and to support medication reconciliation. And now we will focus on outcomes that matter. Evidence of cost-effectiveness of pharmaceutical care on major and patient-centered outcomes in cardiovascular diseases is currently not strong enough to draw firm conclusions. Possible issues are the diversity of pharmaceutical care interventions, a lack of precision in defining the scope of the intervention, the size of the study population, and the lack of RCTs which have investigated relevant clinical endpoints. Clinical endpoints such as hospitalizations and mortality are often not captured. Most often, surrogate parameters like BP or LDL cholesterol levels have been evaluated, although that may be appropriate. The detection and resolution of drug-related problems and the presentation of the number of drug-related problems need to be put into the context of patient outcomes. Most studies have investigated the number of drug-related problems, but had no control group to compare relevant patients' outcomes. Hence, drug-related problems in cardiovascular diseases are currently not a validated surrogate outcome. Often, the study population is small, and therefore the studies are underpowered to detect significant differences in usual composite endpoints in cardiovascular disease. Hence morbidity, that is cardiovascular or heart failure-related hospitalizations, myocardial infarction, or stroke, and cardiovascular or all-cause mortality. In addition, the follow-up period is too short to assess mortality as an outcome. A review further criticized the low quality of study designs according to the JDAD scale. Differences in the design quality as well as differences in interventions and measurements have made it difficult to compare studies, and the conduct of meta-analyses. This does not apply to pharmacists' intervention studies in hypertension, however. In addition to hospitalizations and mortality, health-related quality of life, abbreviated as HRQOL, of cardiovascular disease patients is widely considered to be of increased importance as an outcome measure. It is included in health technology assessments, abbreviated as HTA, and a number of validated instruments are available. For example, the Minnesota Living with Heart Failure Questionnaire, abbreviated as MLHF, or the Kansas City Cardiomyopathy Questionnaire, abbreviated as KCCQ, is widely used in heart failure trials. In chronic heart disease, the Seattle Angina Questionnaire, abbreviated as SAQ, or the Quality of Life After Myocardial Infarction, abbreviated as QLMI, or MAC-NU Heart Disease Quality of Life Questionnaire, MAC-NU, are valid and accepted instruments. For all cardiovascular disease patients, HRQOL is noticeable and influences the entire daily routine. Therefore, future, preferably randomized controlled cardiovascular disease trials of pharmacist care interventions should assess both generic, e.g., EuroQOL, EQ5D, and disease-specific quality of life as secondary, that is patient-related, outcome measures. Economic analyses should also be conducted to determine value for the money spent on pharmacist care interventions. Let's now look at a case scenario. Hypertension and dyslipidemia led to CAD, which led to myocardial infarction, which led to heart failure. Patient Mr. X, male, 69 years old, 179 centimeters, 87 kilograms, has a BMI of 27.2 kilograms per meter squared. Medical history I. Before 2011. Diagnoses: COPD, psoriasis, gout, ulcerative colitis. Pharmaceutical care then. Check elderly patients for cardiovascular risk factors, i.e., measure weight and height and calculate BMI, assess smoking history, and measure blood pressure, BP, heart rate, HR, and lipids, at least total, TC, and low-density lipoprotein cholesterol, LDLC. Note: BP measurement should be performed according to standards. Patients or clients should be seated quietly in a chair with back support, with both feet flat on the floor for at least 5 minutes prior to obtaining a measurement. BP should be checked in both arms at the first examination, at least, and the arm with the higher pressure should be used for subsequent monitoring assessments. It is recommended that the average of at least 2 readings should be taken at an interval of at least 1 minute to represent the patient's or client's BP. If the difference between the first 2 readings is more than 5 mm of mercury, 1 or 2 additional readings should be obtained, and the average of the multiple readings should be used. Cardiovascular risk factors screened by pharmacists are as follows. Slightly elevated BMI, current smoker, for over 40 years, high BP, that is 150 systolic 92 diastolic, and elevated LDL-C level, 185 mg per deciliter, corresponding to 4.8 millimoles per liter, non-fasting. Off a structured smoking cessation program including nicotine replacement therapy, abbreviated as NRT. Refer to GP with documented cardiovascular risk factors. GP diagnosis of cardiovascular risk conditions, hypertension and dyslipidemia. Cardiovascular medication prescribed, RX, are as follows. Enalapril 10 mg twice a day, atorvastatin 20 mg daily. Pharmaceutical care 2. Monitor for medication non-adherence and potential AE or ADR. Intervene as appropriate. Medical history 2. Taken in 2012. Large anterior myocardial infarction, single vessel disease. Cardiovascular medication include aspirin dosed at 100 mg daily, bisoprolol 10 mg daily, enalapril 10 mg twice daily, atorvastatin 20 mg daily. Medical history 3 taken in 2016. Hospitalization for decompensated heart failure. New diagnoses: heart failure, NIHA class 3 to 4, recompensated, type 2 diabetes mellitus. BP, 105 systolic 70 diastolic measured using his right arm while sitting. Heart rate of 85 beats per minute. Sinus rhythm, SR. Laboratory results. Potassium levels of 4.8 milliequivalents per liter. eGFR of 45 milliliters per minute per 1.73 meters squared. Cardiovascular medication include aspirin dosed at 100 mg daily, furosemide 40 mg twice daily, bisoprolol 10 mg daily, enalapril 10 mg twice daily, atorvastatin 20 mg daily. Other medication include metformin 500 mg twice daily. Pharmaceutical care 3. Medication review. 3 weeks following discharge. Make an appointment for a medication review and ask patient to bring his entire medication, prescription and OTC, in a brown bag. Pause the video and carefully scrutinize a table summarizing his medication details. Before advancing to the next slide. Pause the video and carefully scrutinize a table summarizing his medication details. Before advancing to the next slide. Document drug-related problems and intervene as mentioned above. Follow-up was done in mid-2017. He is in New York Heart Association Class 2. His BP is 115 systolic 78 diastolic. His heart rate is 82 beats per minute, in sinus rhythm. Cardiovascular medication include aspirin 100 mg daily, furosemide 20 mg daily, bisoprolol 1.25 mg daily, increased by 1.25 mg every 14 days, 5 mg daily, if tolerated, enalapril 10 mg twice. Atorvastatin 40 mg daily. Other medications include metformin 500 mg twice, allopurinol 100 mg daily, COPD medication. OTC medication include paracetamol 500, acetaminophen 1000 mg as needed, maximum dose of 3 grams daily. Pharmaceutical care for check inhalation technique, metered dose, abbreviated as MDI, and dry powder inhaler, abbreviated as DPI, and intervene as needed. Check heart rate during and after up-titration of bisoprolol, goal 60 to 70 beats per minute. Offer follow-up medication review, as above. One result of this medication review is a medication plan for Mr. X, consolidated by Mr. X, his GP, and his pharmacist, see below. Pause the video and carefully scrutinize a table summarizing medication plan for Mr. X, as of the 6th of September 2017, before advancing to the next slide. Thank you.